So next for the keynote address, I would like to invite none other than our Dr. Pravin Krishna, who needs no introduction. He's the director of Shantilal Chandri Cornea Institute at the L.V. Prasad Eye Institute. He's a meticulous and a brilliant surgeon, and anybody who's seen his surgeries become their instant fans.
Having me speak a little later in the session, and for the keynote, I thought that all of you would have seen plenty of surgical videos of DLEC and DSEC and transplants. So I thought I'll approach it a little differently. I thought I'll speak about talking about how endothelial transplantation really evolved, very little bit about that. What are the current trends in changing trends in transplantation? Where the real challenges for endothelial keratoplasty really lie, and what to look forward to, and if all of us will have a job in about 10 years' time. So quickly, at this point of time, if you look at the evolution of transplantation, endothelial keratoplasty is considered as the pinnacle of corneal transplantation, both from the fact that we don't have any sutures, and also from the fact that the potential visual acuity is as good as you would have with surgery. And the different indications for transplantation are actually very varied around the world. And if you consider the indications for corneal transplants in developed countries, like in the US, Canada, and UK, you'll see that close to 50% of their indications, at least their top indications like BVK, Fuchs, and failed grafts, are patients who have endothelial disorders. Whereas transplants that are done in developing countries, only about 20% of patients in developing countries are patients who are suitable for endothelial transplants, and most of our other problems are bigger problems like corneal scars and infections. And in fact, the burden of blindness is much more in countries that are developing as compared to developed countries. And the commonest reasons for corneal transplants in India, at least, have very good outcomes for diseases that have good outcomes for following corneal transplants in the West, like PBK, corneal dystrophies, and keratoconus, where you have 1-year survivals in the 80s and the 90s. Whereas you have diseases like corneal scars, regrafts especially, you have abysmal survival rates in our population, with 1 in 5 grafts staying clear at the end of 5 years. So now, using this data, we also went and looked at what does the EBAA say from the perspective of endothelial transplants versus regular transplants. Interestingly, the number of transplants in the US seems to be growing every year. Even during COVID, there was a slight fall, but there seems to be a resurgence there. And the most common reasons for corneal transplantation in the US, the blue bars are PK, the red bars are EK, are pseudophakic bullous keratopathy, endothelial dystrophy, which is mainly Fuchs, regrafts, and M is unclassified endothelial disorders. So in fact, the majority of transplants that are done in the US right now are because of endothelial diseases. And also the graph of penetrating keratoplasty and DSEC, which is the blue and the red line respectively, seems to be dropping every passing year, whereas the number of DMECs that are done in the US is actually rising every year. Now, is this something that can be replicated, and is this something that we expect to happen in India as well? If you look at this graph, which is the number of tissues that we sourced in the LVP network, I think there was a brief dip during COVID, but this seems to be increasing as well. And in the network of centers that LVP has, when we reviewed the number of patients who had corneal diseases in the last 35 years, we found that of the 400,000 patients who came in, only a small, minuscule number were patients who had endothelial disorders. So in effect, what we see as a trend of increasing number of EKs around the world may not be really applicable to us, because we don't see that many patients who have endothelial disorders only. What about the number of keratoplasties? We apparently did about 33,000 keratoplasties in the last 35 years, and these keratoplasties actually are the little pink bits on top, which is actually minuscule compared to the number of corneal surgeries that are done otherwise in an organization. And when we plotted the number of keratoplasties along with the indications, we found that the most common indication for us is still therapeutic transplants, infections, which continues to grow up each passing year. Endothelial keratoplasty seems to be growing, but seems to have reached a bit of a plateau. Regrafts actually have fallen in the last 5 years, so have transplants for corneal scars, dystrophies, as well as corrective. So it seems as if there is a growing trend for transplants for infection, partially for endothelial transplants, but also there's a decline in every other area. Amongst all the transplants that we do, we found that the third most common type of transplants that are done in LVP are for endothelial keratoplasty, and also is the third most common indication for corneal transplantation. And of the 6,000 endothelial transplants that have been done, mainly over the last 10 years or so, we found that endothelial disorders, mainly post-cataract surgery corneal edema, was the #1 reason for endothelial transplants, followed by failed grafts, and then Fuchs dystrophy. We also found some interesting data where the majority of patients, as expected, are patients who were between 40 and 60-year-old age group. And there was a change in the trend where 2/3 of the patients actually were from better financial status as compared to those who had infections, where 2/3 of the patients were from lower socioeconomic status. 75% of these patients had the graft for the first time, and there was a significant number who had repeat graft as well. Of the different PK surgeries, DSEC versus DMEC, we also seem to be doing more DMEC in patients who have Fuchs dystrophy, whereas patients who have corneal edema post-cataract surgery, DSEC still is the predominant surgery that is done. Interestingly, graft survival at the end of 5 years following endothelial keratoplasty is about 70%, which seems to be quite decent compared to PK, which is about 50% or so from older population literature. So I'll also take a few minutes more, if you don't mind, to actually go through some of the interesting challenges of DMEC versus DSEC at this point of time, and also the decision about whether DMEC is a sexier, better surgery than DSEC at this point of time. Apparently, there are several reasons why DMEC scores over DSEC. One, obviously, the fact that DSEC anatomically is not exactly very natural, whereas DMEC, you can hardly tell apart a patient when DMEC has been done as compared to DSEC. Probably the more important reason is the fact that you have a lesser risk of rejection. In fact, you have an 8-fold reduction in the risk of rejection after DMEC compared to DSEC surgery. And this is the reason why we are trying to do more DMECs post-penetrating keratoplasty failed grafts, albeit with lesser surgical success. But once you do a DMEC post-PK, it seems that these grafts do better than if you do a DSEC in these patients. You also have better visual quality. There's a higher percentage of patients who achieve 20/20 vision after DMEC as compared to DSEC. More predictable IOL power. In fact, we are doing multifocal IOLs. We're doing toric IOLs along with DMEC surgery because the IOL power is only about 0.5 of what you are actually planning from the perspective of implantation. Visual recovery is much faster, and you'll see that this patient with PBK, that is day 1 after DMEC, and in about 3 days or so, the patient actually has pretty good vision in the majority of cases after DMEC surgery. The surgery is uncomplicated. And lastly, refractive predictability is also good because in DSEC, the smallest potential incision you can make for injecting the lenticule is about 4.5 millimeters, whereas in DMEC, you have injectors right now that can deliver the tissue within a 2.2 millimeter incision, thus reducing the amount of astigmatism that you will induce. So the question now is the fact that DMEC is such a good surgery with such great outcomes, and is it the pinnacle of all corneal transplants that the future has to see? There are still a number of patients where DSEC is better than DMEC, where you have poor visibility and you have patient comorbidities that do not allow the patient to lie down. But also, what is interesting is when you look at the meta-analysis of comparing DSEC versus DMEC, DMEC scores over DSEC in every study when it comes to visual acuity. But when it comes to endothelial cell density, especially long-term endothelial cell density, DSEC is still better than DMEC. So the potential longevity of a graft is better with DSEC as compared to DMEC. Similarly, rebubbling rates also are better with or lesser with DSEC as compared to DMEC. So what does the future hold for endothelial keratoplasty as a surgical procedure, and do we really need to put in a lot of effort to learn and get better with these surgeries? Potentially not. Some of the earliest results of patients from DSO or DVEC show that this is not a viable option for the future. future, because this only seems to postpone the need for endothelial keratoplasty. It probably cannot replace endothelial keratoplasty. But the real exciting news is from Kinoshita's group, which came out with this paper about 5 years ago in 2018. All of you remember this paper about culture endothelial cells with a ROCK inhibitor. And 2 years ago, they reported the 5-year outcomes of the initial 11 patients who had endothelial cell transplantation following culture in the laboratory. And it seems that 10 out of 12 patients are still doing very well from the initial cohort with sustained improvement in visual acuity, though the morphological features in the endothelium are not exactly very good. In addition to this, there also are some very exciting work that is going on from a Korean group of doctors who also been able to transform fibroblasts into endothelial cells and found moderate success in rabbit eyes. And there also have been novel ROCK inhibitors that are being discovered by several pharmacologists, and also people who are trying to do cell engineering by changing the mitochondria function in patients with fugues, potentially changing the game for colon transplantation in the future as well. But probably the most exciting article that at least I have read in the recent past is something that is very similar to SLED. And this is from the Singapore National Licensor Group. Anand, you know this. Jodhbir's group has been doing a lot of good work in reculturing endothelial cells in the laboratory, but they've also found that if you take cells, if you separate them and you inject them inside another recipient without having to culture or expand them in the laboratory, it still has the potential to clear the cornea, and this might be the future of doing colon transplantation of the endothelium. So to summarize, where endothelial keratoplasty is potentially going to be in about 5 to 7 years' time, PK obviously is going nowhere because we still have so many scars, we have so many infections. DSEC and DMEC eventually will be replaced by cell-based therapy. So don't worry if you are not having very good outcomes with DSEC and DMEC, you'll probably just need to know how to inject in the future. There also is going to be a lot of shift towards cell-based engineering and novel drugs for fugues. Potentially, eye banks will cease to exist in the way that we know them right now. They will become cell and tissue banks in the future. And eventually, you also are going to have models using ML and AI to predict outcomes of transplantation before you actually do the surgery. So this is what seems to be the future for endothelial keratoplasty, and it seems that we don't have to put in a lot of effort to learn DMEC or DSEC at this point of time. Thank you.
That was very enlightening talk, Dr.